we're looking into the literature and we're looking at how to measure the outcome of different treatments, I can look into the global burden of disease, the Lancet papers describing the global burden of different diseases all around the world. During the years, the global burden has used mortality as outcome. In the later years, they have used years lived with disability and disability adjusted life years. What does that mean? It means that we now change from mortality as a definite outcome into outcomes defining the whole functional of a person. The disability adjusted life years, it's a combined measure, and it's a combined measure of information taken from databases from all over the world, databases from different studies, from civil registrations, statistics, and health service use. And those information, it's put together and they have defined an outcome called disability adjusted life years. Using that, they describe, for instance, low back pain as a major important disease focusing on disability. And we can see from 1990 into 2019, the burden of low back pain raises. And still we have to remember that disability is a combined in the information on the person's pain, activity level, and the whole participation, the way they can act in daily living. So it's a combined outcome. And what I think is that we have to look into combined outcomes as that when we want to combine, and we have to define what we're doing in musculoskeletal medicine. If we're looking into the outcome, it's a result of consequence or of an consequence of an intervention or result of what we're doing. In musculoskeletal medicine, the consequence of the pain or our treatment can be relief of pain, it can be normalized movement pattern, normalized level of activity, normalized level of quality of life. As you have seen from the previous papers, we use different kinds of outcome to define the effect of what we're doing. Besides the consequence of what we're doing, then we have to define the intervention. That might be diagnostic procedures, specific treatments done, and we have to look into the consultation as a whole. It's important to specifically define what we're looking at to define the outcome we want to measure. Before we can define whether we have treated and we have gained what we want, we have to define baseline. And we have specifically to describe the intervention. And at last, we have to take confounders into consideration because our patients, they're different. If we're looking into RCTs, we do not need to take all confounders into consideration, but if we're looking into bigger cohorts of patients, we have to be aware of confounders. Looking at the papers describing effect of manual work or musculoskeletal treatment, usually we look at VAS, defining differences in pain scores before and after treatment. And in other studies, we look into more activity-based measures as Roland Morris or Visual Disability Index, or we even use quality measures as IQ5D. In other studies, we look into Work Disability Index and more psychological indexes as HATS. Looking into Roland Morris, what does it tell us and how do we use it? Roland Morris is a scoring system. It's a questionnaire including 24 questions, and all questions they are asked, do you have or can you do this and that? And all the questions, they are answered as yes or no. And the scores, they are combined in a score from 0 to 24. Those are the questions asked, some of the questions asked in the Rowland-Morris low back pain disability questionnaire. The Rowland-Morris is used as baseline, as an outcome in lots of different studies focusing on treatment, specific treatment in musculoskeletal medicine, and in other treatments papers looking into effect of, for instance, surgery and training sessions. We wanted to look into whether Rowland-Morris described all the whole framework of ICF. ICF is an elaborated framework done by the WHO group, and it describes the framework including information on the whole health condition of every patient, on body function, activities, participation, environmental factors, and personal factors. The ICF group, they have proposed a core set, and it's defined as the brief core set and a comprehensive core set. We wanted to look into whether the Rowland-Morris or the SF-36, also used in musculoskeletal medicine, the questions in those questionnaires, are they included in the ICF or vice versa? So we went through the whole questionnaire score systems and figured out that the Rowland-Morris mostly looked at activity level or activity functioning in patients compared to the core set. The core set included more questions on environmental factors and personal factors than the Rowland-Morris. The Rowland-Morris also included other factors than the brief core set. Why did we want to look into the brief core set used for daily use? It was because we want to elaborate, not using only activity scores defining our patients, but also we wanted to include information on confounders as environmental factors. To evaluate or to elaborate a questionnaire including all the items from the ICF, we used focus groups including patients and clinicians to help us to define questions and to validate questions. From that, we did a new questionnaire, and it's a quite different questionnaire from the Rowland-Morris questionnaire. It includes all the items from the ICF, and it includes the grade of the disability the patients or the clinicians define according to the item. And as you can see in the picture, we have the red bars and we have the yellow and the green bars, meaning that the green bars, those items, the patients or the clinicians do not find that item as a problem according to the daily activity or the health of the individual patient. But all the red bars, they were problems. So patients having back pain and leg pain, they scored high in pain intensity. But in other activity items, they didn't score that high. And we thought that we could use this kind of scoring system as baseline information, as well as outcome information before and after treatments. It was a whole treatment setting we did. But we figured out that we cannot do that, because when we use lots of items defining, or we use the ICF items defining the whole situation of the patients, we cannot use those information as a combined measure as goal setting. Therefore, we suggested that if you use the ICF core sets, then you have to develop individualized goals, focusing on what do you want to measure, what kind of effect do you want to measure doing, for instance, treatment, or if you do more activity-based activities, what kind of functioning do you want to achieve? as you want to define if you want the patient to participate in social life or in work. Then you have to define specifically the goal of what you want to achieve. Beside that, we have tried to look into registers, and we wanted to look at what kind of outcomes can you achieve from registers. I told you that the global burden group, they use a combined measure. What we have tried in Denmark is that we have tried to use more specific outcomes, defining what happens before and after treatment procedures. It's when we move from smaller groups into bigger groups, cohorts, including, for instance, 2 million people, then we cannot ask everybody about how they feel and how they're doing. Then we have to use other kinds of measures. So when you look into registers and you want to define outcomes, then you can use, for instance, use of opioids during time, days of sick leave before and after treatment, or you can even use the definition of permanent disability pension. And you can use number of procedures because that's information given in the registers. As an example, we have tried to look into use of opioids before the patients, they arrive to a spine center. And we looked at whether patients having surgery changed more or less than patients not having surgery. And we know that those are different patient groups, but at the same time, we can focus, we are able to focus on whether the use of opioids diminish during time according to the national clinical guidelines. At the left, you can see the group of patients who do not use opioids before they are referred to the spine center. And you can actually see that the patients, surgery or not, they use opioids from the beginning and all the way through the following year. If they use opioids before the first contact, the frequencies of the opioid use 1 year after is higher, but the level is nearly equal. The patients having pain indicating surgery, they have more pain when they are first seen at the spine center, but after 1 year, they are quite equal. How can we use that? We can use this to define whether the patients, they actually, they are ordered opioids. And we can see whether we follow the national guidelines reducing the opioid use. And I'm sorry to say that at the time being, we don't follow the national clinical guidelines. So we use this for educational purposes in our spine centers. On conclusion of this, I want to underline that the outcome has to be specified for what you want to show. You have to look into, do you want to look at a specific treatment in a little group, and do you want to look whether a specific treatment is effectful? Then you can look at the outcomes defined as VAS pain measurements, or you can look into more activity-based measures. If you're looking into bigger groups, you have to take into account the environmental factors and the personal factors. And I really think that the ICF core set gives us a basis describing different areas to be taken into account when you want to describe the effect of musculoskeletal medicine. For instance, if you want to treat specifically, you can look into items defining the body function. If you look into more the whole group-based sessions, for instance, education and activity-based treatment, then you have to take into account the environmental factors and the effects of coping strategies among patients. So We can use the ICF core set, the brief core set, defining the framework, but we have also shown that we cannot use the measure of the individual items as outcome in patients having musculoskeletal disease. Thank you very much.